All right, books are open, highlighters are uncapped, and the coffee is, frankly, way too strong.
Yeah.
I am vibrating.
Sounds like you're ready.
I think so. Welcome back to the Deep Dive. Today, we're doing something a little different. We are simulating a high-pressure environment that I think a lot of our listeners know all too well.
That's right. Usually we just unpack a topic casually. Today, we're going to grill you on it. We are simulating the exam hall.
Exactly. I am stepping into the shoes of the exhausted resident, the postgraduate student, preparing for the MD anesthesiology exams at Gujarat University. And you.
I am the senior faculty. I'm the external examiner who's just flown in. I'm looking over the rim of my glasses, and I'm waiting for you to slip up.
So you can fail me.
I am the gatekeeper, and I'm holding the marking sheet. And the topic on the table today is, well, it's an absolute favorite of Indian examiners. If you don't know this, you don't pass.
Anemia in pregnancy.
We're talking about anemia in pregnancy.
It's the bread and butter of obstetrics, right?
Yeah.
We've pulled a serious stack of sources for this revision to make sure I survive this viva. We've got the standard Bibles, Miller's Anesthesia, Morgan and Mikhail.
The essentials.
I've got Guyton for the deep physiology, and specifically for the exam structure, we're looking at the ARC and Kaushik-Jathinath review protocols. The goal here is to make this session bulletproof.
Examiner proof.
Examiner proof.
Then let's not waste time. You walk into the exam hall, you pick up the paper. Question 1 is a 20-mark long answer on anemia in pregnancy. Or maybe you're at the table, Viva. First things first, candidate, frame the problem. Why is this topic on the exam?
Okay. It's on the exam because it's everywhere in the wards.
Yeah.
I mean, the prevalence is massive. The ARC sources cite that anywhere from 40% to, 80% of pregnant women in India are anemic.
40 to 80%.
It's a public health crisis that bleeds literally into anesthesia.
Okay, prevalence is high. But why do I, as an anesthetist, care? Why isn't this just a problem for the obstetrician to fix with some iron tablets? Why are you, the anesthetist, worried?
Because of the concept of maternal reserve.
Go on.
A normal pregnancy is already a massive stress test for the cardiovascular system. The heart is working harder, the oxygen demand is higher. If you add anemia to that, you are stripping away the safety net. The patient has no buffer.
Explain buffer. What does that mean in practical terms?
Well, in obstetrics, hemorrhage is always the looming threat, right?
Yeah.
A healthy mother can lose 500 milliliters or even a liter of blood and compensate because she has the red cell mass to spare.
He has the reserve.
An anemic mother, she's already maxed out. She can't withstand the blood loss, and she can't guarantee oxygen delivery to the fetus. She is walking a tightrope.
Correct. If you cannot manage an anemic parturient, you cannot be an anesthesiologist. So let's get into the weeds. Define it. Don't just give me a generic low blood. Give me the numbers.
Okay, sticking strictly to the WHO guidelines found in our source material. Anemia in pregnancy is defined as a hemoglobin less than 11 grams per deciliter.
Or
a hematocrit less than 33%. And that applies to the first and third trimesters.
And the second trimester. Does that change?
Yes, the bar lowers slightly. In the second trimester, the cutoff is hemoglobin less than 10.5 grams per deciliter.
Why the dip? Is the patient getting sicker?
No, sir. It's physiological. The plasma volume expansion peaks during that second trimester, specifically around 30 to 34 weeks. So the dilution is at its worst then.
So the body is effectively watering down the soup.
Exactly. It's watering down the soup.
Good analogy. But is there a floor to this? A point where we say, okay, this is no longer physiological?
Yes. There is an absolute floor. If the hemoglobin is below 10 grams per deciliter at any point during pregnancy, that is anemia. No excuses about physiology. That requires investigation.
It does. That's the definition. You've set the stage. Now let's move to part A of your answer. Fundamentals. This is where you show the examiner you understand the mechanism, not just the definition. Talk to me about the hematological changes.
Okay, so this is the concept of physiological anemia. Pregnancy is a state of volume expansion. It's driven hormonally.
Which hormones?
Estrogen and progesterone. They act on the renin-angiotensin-aldosterone system, the RAAS. Essentially, the body decides to hoard salt and water.
Why? What's the purpose?
To prepare for the blood loss of delivery. It's an anticipatory measure.
How much water are we talking about? Is it a small change?
No, it's a flood. Plasma volume increases by about 45 to 50%. It starts early, around 6 weeks, and as I mentioned, it peaks around 30 to 34 weeks. That's a massive increase in the fluid component of the blood.
A 50% increase. And the solid component. The red cells, do they just sit there and get diluted?
No, they try to keep up. Erythropoietin EPO kicks in, stimulating the bone marrow to churn out more RBCs. But The marrow is just slower than the fluid retention.
How much slower?
Well, the RBC mass only increases by about 20 to 30%.
So do the math for me. What's the result?
You have a 50% increase in the bucket size, the plasma, but only a 20% or 30% increase in the red balls floating in it. The result is inevitably dilution. The concentration drops. That is physiological anemia.
Now, here's a question that separates the past from the distinction. Is this dilutional anemia a design flaw? Is nature making a mistake?
No, it's actually a feature, not a bug. It has a compensatory benefit.
Which is?
Because the blood is more dilute, the viscosity, the thickness decreases.
And why is low viscosity a good thing in pregnancy?
Rheology. Thinner blood flows more easily. It reduces the resistance in the vessels, the SVR, and that does two things. It decreases the afterload the heart has to pump against.
So it's less work for the heart.
Right. And crucially, it helps maintain the patency of the utero-placental vascular bed. It keeps the microcirculation to the baby open.
Exactly. If the blood were too thick, say if the hematocrit stayed high while the volume increased, you'd risk sludging in those low-pressure placental vessels.
You'd have a traffic jam.
Traffic jam. So the drop in hemoglobin concentrations, say from 14 down to 12, is the price we pay for better flow. But does this mean the mother is suffocating? Is she oxygen deprived?
No. Even though the concentration of oxygen per milliliter is lower, the total amount of oxygen delivered is maintained.
How? That sounds like a contradiction.
Cardiac output.
Bruh.
The heart pumps more volume. It speeds up. The stroke volume increases. So you're delivering thinner blood, but you're delivering a lot more of it per minute.
Precise. That is the baseline. That is the normal pregnant patient. She is compensated. Now let's break that compensation. Part B, classification and pathophysiology. When does it become pathological?
When we drop below that 10-gram cutoff, then we have to classify it by etiology. For the exam, specifically in the Indian context, the 800-pound gorilla is nutritional anemia.
Break it down for me.
Iron deficiency is the massive one. The sources say about 60% of cases in our setting. It's simple supply and demand. The pregnancy demands about 1,000 milligrams of elemental iron explicitly for the fetus and the expanded red cell mass.
1,000 milligrams.
Yes. And if the mother's stores are low to begin with, she runs dry.
There's a specific cultural point mentioned in the texts regarding the diet in India. The examiners at Gujarat University will want to hear this.
Right, the phytates. The text highlights that diets high in cereals and chapati contain phytates, which they inhibit iron absorption in the gut.
Right.
Plus, vegetarian diets often lack heme iron, which is the easily absorbed kind found in meat. And then there's the habit of drinking tea with meals. The tannins also block absorption.
It's a perfect storm for iron deficiency.
Oh, that's a big storm.
It is. Mentioning phytates and tannins is a great way to score points. It shows you understand the patient population, not just the abstract science. What else besides iron?
Megaloblastic anemia, usually folate or B12 deficiency. The sources note that folate deficiency almost always tags along with iron deficiency. It's rarely isolated.
That makes sense.
Yeah, if a patient is malnourished enough to lack iron, they likely lack folate too.
Okay, so that's nutritional. What are the other buckets we need to think about?
Hemorrhagic. That can be acute, like an antepartum hemorrhage placenta previa or abruption, or chronic. In rural areas, hookworm infestation is a major cause of chronic blood loss.
You can't forget that.
Or even just bleeding hemorrhoids, which are common in pregnancy due to venostasis.
Good. Keep going. What else?
Hemolytic anemias, sickle cell, thalassemia. Those are genetic and affect the structure of the hemoglobin. Then anemia of chronic disease renal failure, or TB, which is still prevalent. And finally, bone marrow insufficiency.
Which could be from what?
Could be drug-induced or plastic. But practically, 9 out of 10 times in the exam, we are talking about iron deficiency.
Excellent coverage. Now we are going to get into the core of the exam, the pathophysiology. If you are writing a long answer, you cannot just describe the symptoms. You must explain the mechanism of survival. Walk me through the oxygen flux equation.
This is the golden equation for anesthetists. Tissue oxygenation, or DO2, equals cardiac output, CO, multiplied by arterial oxygen content, CaO2.
DO2 equals CO times CaO2.
Right.
In anemia, which variable takes the hit?
The CO2. The oxygen content drops because there is less hemoglobin to carry the oxygen. It's a supply chain failure.
So the body looks at that equation. The left side tissue oxygenation must stay stable or the organs die. The right side has a low content. So the body has to manipulate the other variables. What are the three pillars of compensation?
Okay, pillar one is cardiac output. We touched on this. The heart beats faster and pumps harder, increased stroke volume. It circulates the thin blood faster to ensure the tissues see the same number of oxygen molecules per minute.
Correct. But there's a limit to how fast the heart can beat. What is pillar two?
This one is biochemistry, the two-filled DPG increase.
Explain this to me like I'm a first-year medical student. Don't just name it.
Okay, so hemoglobin is the bus that carries oxygen. Normally, it holds on to oxygen fairly tightly until it gets to a really hungry tissue. Two-filled EPG is a molecule inside the red blood cell. When it increases, it kind of wedges itself into the hemoglobin structure and forces it to relax its grip.
It lowers the affinity for oxygen.
Exactly. It causes a rightward shift of the oxyhemoglobin dissociation curve. It means that for any given level of oxygen in the blood, the hemoglobin is more willing to dump it off to the tissues. It becomes a more generous donor.
The mnemonic is right release.
Right release.
Yes,
So,
good release. That's the mnemonic. And pillar three.
redistribution. The body enters survival mode. It becomes ruthless. It shunts blood flow to the vital organs, the brain, the heart, and the placenta.
At the expense of what?
It constricts flow to the non-essential organs like the skin and the kidneys.
Precisely. So we have a heart that is racing, blood chemistry that is altered, and a vascular system that is clamped down in the periphery. Now, connect this back to what we said in the intro. Why is this mother at risk?
Because she is doing all of this just to sit in a chair. She is maxed out at rest, her heart rate is already high, her 2,3 DPG is peaked, her flow is redistributed. So if I add the stress of labor or if I accidentally drop her blood pressure with an epidural, she has no gears left to shift into. Her reserve is zero.
That is the key sentence. Reduced reserve. She cannot compensate for further insults. Let's look at the consequence of that. Part C, maternal and fetal effects. Start with the mother. What is the nightmare scenario?
High output cardiac failure. The heart is pumping so much volume against low resistance that it eventually it gives up. It gets exhausted.
When is that risk highest?
It tracks with the plasma volume, so 30 to 32 weeks is dangerous, but the absolute peak risk is immediately postpartum.
Why postpartum? The stress of delivery is over.
Because when the baby is delivered, the uterus contracts and squeezes all that blood back into the circulation. It's called autotransfusion. Plus, the pressure on the vena cava is released. The heart gets hit with a massive volume load right when it's tired.
We'll talk about managing that later. What about the general health effects?
It's a miserable existence. Fatigue, reduced exercise tolerance, palpitations. You can see things like glossitis, swollen tongue, and stomatitis.
And specifically for us, the anesthetic risk, the thing that should keep us awake at night.
It's hypoxia. This is about the FRC, the functional residual capacity. Pregnant women already have a small FRC because the uterus pushes the diaphragm up. They have less oxygen in their lungs to rely on if they stop breathing.
And if you add anemia,
You add anemia-less oxygen in the blood, and you have a recipe for disaster. If an anemic pregnant patient stops breathing during intubation, she desaturates in seconds.
correct. The time to desaturation is terrifyingly short. Now look at the fetus. There's a saying in the texts, the fetus is a parasite, but a successful one. What does that mean?
It means the fetus usually takes what it needs regardless of the mother's state. Fetal hemoglobin has a higher affinity for oxygen than maternal hemoglobin. It's designed to literally strip oxygen from the mother's blood across the placenta,
So the baby is fine.
only up to a point. If the maternal anemia is severe enough, the parasite starts to starve. The supply chain breaks down.
And the outcomes, what do we see?
Intrauterine growth restriction, or IUGR, is the big one. The fetus conserves energy by stopping growth. You get low birth weight, preterm delivery.
And during labor,
These babies tolerate stress poorly. You see a higher incidence of birth asphyxia and poor ABGAR scores.
exactly. The fetus is living on the edge, just like the mother. Fetal renal erythropoietin actually goes up. The baby is trying to make more blood just to survive inside the womb.
That's a stark image. Both of them just struggling for oxygen.
It is, and that is why we intervene. Moving to Part D, anesthetic management. This is the practical how-to part of the exam. You are in the pre-op clinic, a pregnant patient walks in. How do you grade the severity?
We use the WHO grading, adapted for our context. Mild anemia is hemoglobin 10 to 10.9.
Moderate.
Moderate is 7 to 9.9. And severe is less than 7 grams per deciliter. And very severe is often cited as less than 4. But really, below 7, we are in the danger zone.
You're examining the patient. What are you looking for?
I'm looking for signs of decompensation. Is she dyspneic at rest? Does she have ankle edema that looks pathological, not just the usual pregnancy swelling? I'm checking the JVP as the neck vein distended. I'm listening to the lung bases for crepitation fluid in the lungs, which would suggest heart failure.
And the etiology clues, the things that point you to the cause.
I'm looking at the nails for Coelinekia, those stone-shaped nails that just scream iron deficiency. I'm looking at the tongue for glossitis, and of course, checking the peripheral smear results. Is it microcytic, small cells, or macrocytic, large cells? We need to know the cause to treat it properly.
Speaking of treatment, let's talk about optimization. This is a favorite exam question because it's controversial. When do we transfuse?
We have to be very careful here. The reflex to just top them up is wrong. For iron deficiency, the first line is iron therapy.
Oral or BIF?
Oral prophylaxis, 60 milligrams of elemental iron per day, is standard. If they are anemic, we bump that up to therapeutic doses.
But oral iron takes weeks to work. What if she's 36 weeks pregnant and coming for an elective section?
Then we go to parenteral iron, Phi iron. It works much, much faster. Sucrose or carboxymaltose formulations are common now. They replenish the stores much faster than the gut can absorb.
And the Viva warning regarding parenteral iron. What's the risk?
Anaphylaxis.
Yeah.
Especially with the older iron dextrin formulations. You never just hang the bag and walk away. You need a test dose, and you need resuscitation drugs, epinephrine nearby.
Good, but now the blood transfusion triggers. This is where students get tripped up. I am the examiner. I ask you, doctor, this patient has a hemoglobin of 8.5. She's feeling tired. Why don't we just give her a unit of packed cells?
I would say, no, sir. Transfusion is not a tonic for fatigue. It is a transplant of liquid tissue with serious risks.
Such as?
Transfusion reactions, tracheal lung injury, circulatory overload infection, immunomodulation. The list is long.
So what are your triggers? Give me the numbers.
If the HB is less than 6, transfusion is definitely indicated. The risk of hypoxia outweighs the risk of the blood. If it's greater than 10, it's rarely indicated.
And in between?
The problem is the gray zone, between 7 and 9.
How do you navigate the gray zone?
Clinical judgment. You don't treat the number, you treat the patient. Is she symptomatic? Does she have heart disease? What is the anticipated blood loss?
You give me an example.
Okay, if she's having a placenta previa C-section, where I expect her to bleed a liter, I might transfuse at 8 to build a buffer. If she's having a normal delivery with minimal expected loss, I might wait and watch.
There is a very specific physiological point regarding the timing of transfusion before surgery. If you decide to transfuse, when do you do it?
Ideally, at least 24 hours prior to surgery.
Why? What happens in those 24 hours?
It goes back to our friend 2003 DPG. Stored blood in a bag loses its 2003 DPG over time. The red cells become selfish. They hold on to oxygen too tightly.
So they don't release it to the tissues.
Exactly. It takes about 24 hours inside the body for the 2-3 DPG levels in those transfused cells to regenerate.
Brilliant point. If you transfuse immediately before induction, you are boosting the volume and the hemoglobin count, but you aren't necessarily improving oxygen delivery to the tissues right away.
Because those new cells won't release the oxygen yet.
That's a distinction that definitely earns points.
Good to know.
Now let's take this patient to the labor ward. She's in labor. What is your goal as the anesthetist?
The goal is to minimize cardiac workload. Labor pain causes catecholamine surge adrenaline that spikes the heart rate and clamps down the vessels, increases the SVR. That makes a heart work much, much harder.
And we want to stop that.
We want to stop that.
So the gold standard is?
Regional analgesia, specifically an epidural. Excellent pain relief blunts that sympathetic response. It keeps the heart rate down and reduces cardiac work. It's almost therapeutic for the heart.
Any precautions we need to take with that epidural?
We have to check coagulation status first, obviously. But mainly, we have to be gentle with hemodynamics. An anemic mother relies on her cardiac output.
So what happens if we're not gentle?
If the epidural causes sudden hypotension, we slash her uteroplacental perfusion. She has no oxygen reserve to buffer that drop. We need to load with fluids carefully and titrate the dose slowly.
Exactly. Now, the scenario changes. It's an emergency. She needs a lower segment cesarean section, an LSCS. What is your anesthetic of choice?
Regional is generally preferred over general anesthesia.
Why? Give me 2 reasons.
Okay, 2 reasons. First, the airway. The pregnant airway is difficult due to edema, and failing to intubate an anemic patient leads to death very quickly due to that rapid desaturation we talked about.
And the second reason?
Second, hemodynamic control. With a slow onset regional technique, I can manage the blood pressure better than the roller coaster of GA.
So which technique specifically? A spinal.
A combined spinal epidural, a CSE, or a carefully titrated epidural is ideal. A single-shot spinal is risky.
Why risky? It's fast.
The onset is so fast the sympathectomy hits hard, the BP drops, and the heart might not handle it. If I have to do a spinal, I use a low dose and maybe supplement with the epidural.
But often in exams, they force you into a corner. They give you a scenario where regional is contraindicated. Maybe she has severe coagulopathy or fetal distress that requires immediate delivery. You have to do a GA. Walk me through the dangers.
This is the high-stakes induction.
Huh?
The biggest risk is rapid desaturation. She has high oxygen consumption because of the pregnancy and low oxygen storage because of the anemia and low FRC.
So how do you manage the induction? What's the first step?
Pre-oxygenation is non-negotiable. I need 3 to 5 minutes of tidal breathing or vital capacity breaths with 100% oxygen. I am trying to wash out all the nitrogen and maximize the dissolved oxygen in the plasma. Every molecule counts.
Which induction agent?
I need cardiovascular stability. Propofol drops the blood pressure too much. Thiopentone is a myocardial depressant. Etomidate is probably the safest choice for stability.
What about ketamine?
Ketamine is the other option, but you have to be careful.
Careful, why? Ketamine causes tachycardia. Isn't that bad?
It can be. If the patient is already tachycardic, say, her heart rate is over 110 trying to compensate, giving ketamine might push the heart rate too high and cause decompensation or myocardial ischemia. But if she is hypovolemic or crashing, ketamine supports the pressure. It's a judgment call, but I'd lean toward etomidate if available.
And maintenance of anesthesia.
High FiO2. I am not going to run her on 30% oxygen and air. I'll keep it at 50% or higher.
Yeah.
I need to keep the dissolved oxygen high, and I'd avoid deep volatile anesthesia, halothane or isoflurane, because they depress the heart muscle.
And why is that so critical here?
The heart is the only thing keeping her alive. Don't weaken it.
Good. You're in the OR, Part E, intraoperative and postoperative care. You're walking a tightrope hemodynamically. Describe that tightrope.
The anemic heart relies on rate and volume. If I let her get hypovolemic low fluid, she loses preload, cardiac output drops, and she crashes. But if I overload her with fluids, her diluted blood and weak heart can't handle it, and she goes into pulmonary edema.
So you have to be aggressive with hypotension, but cautious with fluid volume. How do you do that?
Vasopressors. Phenylephrine is my friend. I use it to maintain pressure vascular tone without having to dump liters of fluid into her, and meticulous attention to blood loss.
You're watching the surgeons.
I'm shouting at the surgeons politely to ensure hemostasis.
Uterotonics. The baby is out. You need the uterus to contract.
Use with extreme caution. A bolus of oxytocin causes significant hypotension and tachycardia via direct vasodilation. That can tip an anemic heart over the edge.
So what do you do instead?
It should be an infusion, strictly. Or use slow, small boluses. No methylorgometrin if she has preeclampsia or heart disease.
Okay, the surgery is done. You're wheeling her to recovery. The student usually relaxes here. Why do I fail them if they relax?
Because this is the danger zone, the immediate postpartum period.
Explain the physiology again. Why is it so dangerous?
The uterus contracts, pushing about 500 milliliters blood back into the systemic circulation. The baby is gone, so the inferior vena cava is wide open, increasing venous return. Essentially, the heart just got hit with a 1-liter fluid bolus in the span of 10 minutes.
And in a patient with borderline failure.
That volume load pushes them into frank pulmonary edema. They start frothing at the mouth in the recovery room.
Precisely. You monitor SEFBO2, vitals, and urine output like a hawk. When do you send them to the ICU?
If the anemia is severe, less than 7, or if there are any signs of cardiac decompensation or instability, better to watch them in ICU than code them on the ward.
Excellent. Let's wrap up with Part F exam integration. Let's talk about the double hit, anemia plus preeclampsia.
That is a nightmare combination. Preeclampsia is a disease of vasospasm. The vessels are tight, so tissue perfusion is poor. Anemia means the blood has low oxygen content.
So you have
poor flow carrying poor blood. The fetus suffers immensely.
And from a management perspective, what's the challenge?
It's tricky. Preeclampsia patients are dry. They have low plasma volume. Anemic patients need volume to maintain output. But the leaky capillaries in preeclampsia mean that fluid leaks into the lungs easily. It is the hardest hemodynamic balance to strike.
What do you need to manage that?
You definitely need invasive monitoring, maybe an arterial line.
Let's cover a classic Viva trap. I show you a case. This patient has meconium-stained liquor. Is that relevant to her anemia?
Yes, it is. It's not just a random finding. Chronic fetal hypoxia due to maternal anemia can trigger fetal distress. That distress causes the fetus to pass meconium.
So the meconium is a sign?
So meconium is a red flag that the anemia is effectively strangling the baby.
Finally, presentation. You are answering the 20-mark question. What diagrams are you drawing?
I am definitely drawing the oxyhemoglobin dissociation curve. I'm drawing 2 lines, the normal curve and the right shifted curve of the anemic mother. explicitly labeling the 2,3-DPG effect.
Why that diagram?
It's a visual way to explain the compensatory mechanism. Examiners love graphs.
And flowcharting? How do you structure the answer?
Structure's everything. I'd flowchart it. Definition, physiology with the numbers, pathology, focusing on iron deficiency, management, broken down into pre-op, intra-op, and post-op. A wall of text gets a low score. A structured answer gets a distinction.
Perfect. Summarize it for the listener. Give me the golden numbers one last time.
HB less than 11 is the definition. Plasma volume plus 50%. RBC mass plus 20%. The gap is the physiological anemia.
And management.
Transfuse if less than 6 or less than 7 with symptoms or anticipated major blood loss. Avoid rapid boluses of oxytocin. And watch out for the postpartum volume overload.
And the final takeaway for the exam. The one sentence you write at the end of your answer.
Link the physiology to the plan. Don't just memorize drugs. Explain why. We maintain cardiac output because the oxygen content is low. We avoid hypoxia because the reserve is low. Safety of the mother ensures safety of the fetus.
You are ready.
I feel ready. My blood pressure is definitely up, but I feel ready.
One last thing. For everyone listening, go practice drawing that dissociation curve right now. Don't just look at it in the book. Draw it. Muscle memory saves you in the exam hall when your brain freezes.
Absolutely. Check the show notes for the WHO grading table and the drug doses we mentioned. Good luck to everyone studying. You've got this.
Class dismissed.